Welcome to Clinical Minute. Janelle is a 19-year-old female who presents for her first visit to the University Clinic for Women's Health. She states that the primary reason for her visit is to find out about switching from an oral contraceptive, which she has taken for about 2 years, to an intrauterine device, or IUD. Janelle is a college sophomore who lives on campus in a dorm suite and works as an assistant manager at a local clothing boutique. She states that she is doing well in school and does not voice any specific medical concerns at this time. She is asymptomatic and her medical history is unremarkable. She states that she drinks alcohol occasionally with her boyfriend and their friends at parties and does not use tobacco or recreational drugs. You inform Janelle that obtaining some information about her sexual history is a routine part of the history and assessment, and ask if she is willing to answer your questions. You assure her that the health information she shares with you is confidential. Janelle agrees to answer your questions. In busy practices and clinics such as yours, it may not be uncommon for healthcare providers to omit taking the sexual history, unless a patient presents with complaints or symptoms of a sexually transmitted infection, or STI. However, obtaining pertinent information about a patient's sexual health and behaviors is a necessary component of the overall assessment. Since Janelle's primary reason for coming to your clinic is to discuss getting another form of birth control, gathering information about her sexual health and history is important. You open a dialogue about Janelle's sexual history by asking her several general screening questions. Have you been sexually active in the last year? Do you have sex with men, women, or both? How many people have you had sex with in the past year? Janelle states that she has been sexually active since age 16 and reports a total of 4 lifetime partners, all males. She began taking oral contraceptives when she was 17. She has been in a sexual relationship with her boyfriend for the last 3 months. You also ask her about any history of STIs. She says she has never had an STI. When asked about protection from STIs, she reports that her boyfriend uses condoms about half the time. You ask Janelle what she knows about the human papillomavirus, or HPV. She shrugs and says, "Isn't that like warts? Is having sex with someone the only way that I can get it?" You take the time to reinforce that risk factors for genital HPV in women include being younger than age 25, starting to have sex at an early age, 16 years or younger, having multiple sex partners, have a partner who has had multiple partners. You know that obtaining information related to her immunization history is also an important part of your intake for this patient. She left the immunization history section blank on her health history form, but states, "I think I'm up to date with my vaccines, but my mom is the one who keeps track of that." When you ask her specifically about the HPV vaccine, she responds, "I'm pretty sure that I had it when I was younger, but I can't remember the year or how many shots I got." Janelle asks about getting screened for HPV, and you advise her that there are no HPV screening recommendations for females under 21 years. You explain further that a Pap test cannot detect if you had or have HPV. However, it will likely detect any cervical cell changes caused by HPV. You are aware that opportunities exist to immunize 18 to 26-year-olds who either did not start or finish the HPV vaccine series. HPV vaccination increased from 20.7% in 2010 to 40.2% in 2014 for females aged 19 to 26 years, and from 2.1% in 2011 to 8.2% in 2014 among males aged 19 to 26 years. In a study that used National Health Interview Survey 2010 data to estimate HPV vaccine coverage, 18 to 20-year-old women were more likely than those 21 to 26 years old to receive 1 dose and 3 doses of HPV vaccine. Unfortunately, a number of barriers to obtaining the HPV vaccine are known to exist in this age group, including health insurance coverage, providers missing the opportunity to endorse HPV vaccine when administering other vaccines, cost, not having a healthcare provider or not seeing one regularly, being foreign-born. Before the end of Janelle's visit, you are able to access your state's electronic immunization registry, which shows that she received one dose of quadrivalent HPV vaccine, Gardasil, at age 14, but she received no subsequent doses. Currently, the only HPV vaccine used in the U.S. is 9-valent HPV. In late 2016, the Centers for Disease Control and Prevention Advisory Committee on Immunization Practices, ACCME, published updated HPV vaccination recommendations, which advise a 2-dose regimen for 9-valent HPV vaccine for all adolescents age 11 or 12 years and catch-up vaccination for females 13 to 26 years and for males 13 to 21 years not adequately vaccinated when they were younger. Adolescents and adults of any age who started the HPV vaccine series prior to their 15th birthday and who are not immunocompromised are considered to be adequately vaccinated with just one additional dose of HPV vaccine, provided the interval between doses is at least 5 months. If a second dose is given 3 months after the first dose, it does not count. For individuals initiating vaccination before their 15th birthday, the recommended immunization schedule is 2 doses of HPV vaccine. The second dose should be administered 6 to 12 months after the first dose. 6 to 12 month schedule. The minimum interval between the first and second doses is 5 months. For individuals initiating vaccination at age 15 through 26 years, or for immunocompromised individuals initiating HPV vaccination age 9 to 26 years, the recommended immunization schedule is 3 doses of HPV vaccine. The second dose should be administered 1 to 2 months after the first dose. 1 to 2, 6-month schedule. In a 3-dose schedule of HPV vaccine, the minimum intervals are 4 weeks between the first and second doses, 12 weeks between the second and third doses, and 5 months between the first and third doses. It is important to note that the 2-dose schedule can be completed with any combination of HPV vaccine brands as long as dose number 1 was given before age 15 years and the 2 doses were separated by at least 5 months. In other words, you can mix and match quadrivalent HPV and 9-valent HPV to complete a patient's vaccination series. Individuals who have received 2 doses of HPV vaccine separated by less than 5 months should still receive a 3rd dose 6 to 12 months after dose number 1 and at least 12 weeks after dose number 2. In Janelle's case, since she received dose number 1 at age 14, you can safely complete the series by administering 1 dose of the 9-valent HPV vaccine. No vaccine series needs to be restarted because of an interval that is longer than recommended, with the exception of oral typhoid vaccine in certain circumstances. You should continue the HPV vaccine series where it was interrupted. If it was begun when the individual is age 26 or younger, it can be completed after age 27. Per the ACCME recommendations, you recommend to Janelle that she receive HPV vaccine today, and that no additional doses are needed. You inquire if Janelle gives consent to getting the HPV vaccine, and she gives verbal agreement. You administer a dose of 9-valent HPV to Janelle, and recommend that her partner check his HPV vaccination records as well, and get vaccinated if he has not already been. Janelle then asks you if she is protected from cervical cancer by completing the HPV vaccine. As you know, HPV is the cause of virtually all cases of cervical cancer, with types 16 and 18 responsible for approximately 70% of all cases. You advise her that the majority of HPV-associated cancers are caused by the types of HPV that are covered by the vaccine. You further explain that HPV is spread through sexual contact and that HPV can cause an infection in the cervix. Most of the time, the infection does not last very long because the body is able to fight it. However, it can last longer in some women. Although very few HPV infections lead to cervical cancer, long-term HPV infections can change cells in the cervix to pre-cancer cells. You then focus the remainder of Janelle's clinic visit on discussing appropriate contraceptive options.